So it's my great pleasure to welcome you all today and thank to Dr. Jakob for this kind invitation to be part of this great event. Unfortunately, I could not join you in Vienna, but I am with my heart and my soul um, along your side. So we will focus in the next minutes to our topic, Introduction to the Thyroid Clinical Ultrasound. Although I just saw in the program that you already got a presentation about thyroid, we will go slowly. So, what is the context that we are dealing with, regardless of our specialty? 15% of adult female population has different type of autoimmune thyroid disease. At least 50% of adult population has ultrasound detectable nodules. Active thyroid screening is recommended by the major endocrine guidelines in females over 35 years of age every 5 years. Iodine deficiency disorder has a broad spectrum of diseases from uninodular to multinodular goiter for hypo to AU and even hyperthyroid cases. And there is a lot of iatrogenic issues coming as long as the use of interferon, sunitinib, amiodarone, lithium, and different type of immunotherapies, especially in small cell lung carcinomas, and not only are more widely or frequent used. When we are considering the prevalence of thyroid nodules in Europe, so fresh data published in 2016 by the ACE AME task force, the prevalence in ultrasound screening is different according to different subpopulation, but actually the general is considered to be up to 70% of women and up to 30% of adult men if we will have a universal screening of all adult population by thyroid ultrasound. I do emphasize that according to the last recommendation, the management of thyroid nodules comprise of two major lines. Golden standard of morphological evaluation is ultrasound and lab-assayed screening with TSH and calcitonin, and only in selected cases SPECT or scintigraphy. So the general use of scintigraphy in evaluation of thyroid nodules is long since 2010, not anymore recommended. This is a caveat for those who still use it for screening, and it's a mistake. So we are using for thyroid ultrasound, which is the first line diagnostic tool in any thyroid disease, besides of course the clinical evaluation and the anamnesis, linear probe, multi-frequency, and actually we have here two examples. We have a higher frequency linear probe that ensures by the same depth of 3 centimeters very fine details, and then we have a lower frequency probe which by the same 3 centimeter depth the fine of the image is different compared with this one. This is the same patient. If we are aiming deeper levels, it goes beyond 4 centimeters, go up to 5 centimeters. This is the higher frequency probe, linear probe, and these are the same depth, more than 4 to 5 centimeters with the lower frequency. So the image here, when we aim deep, is better with lower frequency. So meaning if you want to see the first centimeters, fine details, use higher frequency up to 18 megahertz. If you aim deeper lesions, use lower that go 5 to 10 megahertz. So the regional anatomy should be something that you already all know. We have in transversal section landmarks, the tracheal cartilage on the midline, longus colli, which can be a pitfall for the beginners. We always are happy to see parathyroid, but we are mistaking. The carotis, common carotis artery, very good point. Jugular vein. We have then the strap muscles and the sternocleidomastoid muscle. We never see on ultrasound the nervous structure, although from the anatomic, let's say, slices, we know that we have here the recurrent nerve, which is important for surgical approach. We are using two different scans. We are using transverse scan from anterior to posterior, the same slices, skin, subcutaneous fatty tissue, strap muscle. We have the thyroid with the isthmus on the midline, and right and left lobe in the vast majority of cases. The same anatomic wrapper that we discussed about common carotid artery, jugular vein, longus colli muscle, tracheal, esophagus, and sternocleidomastoidean muscle, with the strap muscles. And of course, we should focus on the midline, on the isthmus. We always check for it and measure it, and whenever the measure is more than 3 millimeters, then we have to count it in the total volume. Another focus image with the esophagus, which in the vast majority of cases is seen behind the posterior face of the left lobe. We have then longitudinal scan. A correct one has always in the picture the cranial or the apical point of the thyroid lobe and the caudal point of thyroid lobe. We see the entire longitudinal scan. We see the same skin, subcutaneous fat, sternocleidomastoidean muscle. Then we see the fat surrounding the thyroid, and of course a good anatomic wrapper, the lateral spinous process of C4, C5, C6. What do we aim when we do conventional ultrasound, even in, let's say, normal thyroid? Once we check for anatomic integrity. So anatomic integrity means first to see the thyroid. And you can have a patient in front of you without any marks of thyroidectomy, without any previous history of treatments of exposure to X-ray or iodine or surgery, who just by chance you look into the correct region and you see the wrapper that we discussed, strap muscle, sternocleidomastoidean, common carotid artery, longus colli, tracheal cartilage, and no thyroid at all on the right side. And the same goes for the left side, that of course you can aim to see better here the esophagus, and here down is the longus colli, but there is no thyroid at all. Of course, the same image you can see even after total thyroidectomy, but you have the chance to discuss with the patient and you know that is not the case. So in such situation, it seems to be a thyroid agenesia, but before completing the diagnostic, you have to double check it and to perform scintigraphy or sestamidi to exclude an ectopia. An example for thyroid ectopia, which we got the chance to make the positive diagnostic by ultrasound, so checking the right region where the thyroid is supposed to be. You see the common carotid artery, the jugular vein, the strap muscle, the sternocleidomastoidean muscle on both sides. You see the longus colli, here tracheal structure, no thyroid at all. And when we scan from downwards to upwards, so we did check it from down, so no thyroid tissue, thyroid level where it's supposed to be, no thyroid tissue. Then we go on the cricoid bone, no thyroid structure. We go upwards, hyoid bone, no thyroid structure. And at the level of submentorial region, we did find two small regions. So this is the first one, which looks like thyroid tissue, and the second one. But of course, this supposed ectopia diagnosed by ultrasound has to be confirmed by a morphofunctional evaluation, checking the capacity of this tissue to uptake iodine. So you have always to double check ectopia or agenesia with scintigraphy. And these are typical conventional Doppler and the last of four thyroid parameters. So this is where we found the tissue that were highly suggestive for parathyroid. You have also the possibility to check by ultrasound the agenesia by itself. So we have on the right side no sign of thyroid lobe, although we have the tracheal cartilage, carotid artery, jugular vein, sternocleidomastoidean, longus colli, non-thyroidal tissue. And on the other side, on the left side, we do find the left lobe whenever with a nodule on it, transverse section, longitudinal section, apical and caudal pole of the thyroid. So this is a typical right lobe agenesia. Of course, I do emphasize you can get the same ultrasound image if you have in front of you lobectomy or right lobectomy, but always discussing with the patient makes also sense and adds diagnostic value. Thyroid volume is the next step that we have to go through. Usually the thyroid volume is by adding right to left volumes, and you compute the right and left lobe volume by making the count of transverse diameter, anterior-posterior via diameter, and craniocaudal diameter, and you make the same measurements for the left lobe, and you measure the isthmus, and whenever this is exceeding 3 millimeters, you have an extra count. Whenever it's less than 3 millimeters, you rest what you get by adding the volume of left to right lobe, and this is the formula, the 3 diameters counted together, and also adding 0.5, and if again more than 3 millimeters isthmus. Of course, the values are orientative. It's not a millimeter type of measurements. It's not, let's say, a millimeter type of decision making diagnostic, but it's orientative, and we will see in the following slides what are we using the volume for in the daily life of the clinicians. The last recommendation about what means good enough or how big should a normal thyroid be comes from the European Union Horizon measurement in 2020. And actually they are recommending upper normal values around 18 millimeters in females and 22 millimeters in males. Of course, gender, age, iodine exposure in the soil, or presence of pregnancy or not does also influence the mean volume at the populational level. But these values, which are valid for 2020 Europe, it's enough, let's say, for an orientative diagnostic when screening thyroid. What do we do also? Check besides thyroid volume, by the same evaluation we also observe the general characteristic of the diffuse parenchyma. So when we are dealing about volume, we could have a decreased volume, and the volume significantly lower than the mean, should be less than 10 or 8 milliliters in males, respectively females, is suggestive for atrophy, which can be the last step of autoimmune thyroid disease evolution, or it can be a decreased volume secondary to a different type of treatments. You could have a normal volume, which means 10 to 18 milliliters in female, 12 to 20 milliliters in males. Whenever you have a physiological case in front of you, or a cured Graves' disease also has a normal volume, and increased volume can be seen in different type of diseases. So you cannot make a typical etiopathogenetic diagnostic when looking into volume. You can go in different direction, but if we are looking to increase volume, granulomatous thyroiditis, Hashimoto variant of thyroiditis, iodine deficiency disorders, even subacute thyroiditis could have an increased volume. So you cannot have a clear diagnostic whenever in front of you have an increased volume, increased isthmus, increased volume. You can have either of these, and this is totally completely different direction from the etiopathogenetic point of view. When we consider echogeneity, so we could have decrease of echogeneity, meaning increased quantities of colloid in iodine deficiency disorders, very severe forms of atrophy where there is no follicular cells active left anymore, but also active graves with increasing shape follicular tissues also would have an increased echogeneity. And when we are dealing with echogeneity, we do not have any other, how should I say, muscle to compare with. Actually, we do compare the echogeneity not with the sternocleidomastoidean muscle, because somehow low echogeneity in thyroid is almost identical to this sternocleidomastoidean or strep muscle. We are actually comparing the thyroid from the echogenetic point of view with the echogeneity of of a salivary glands, typical the maxillary submandibulary salivary glands, and this is how thyroid normal echogeneity should look like. So this is the normal echogeneity. So again, do not make how should I say, a comparison to the surrounding muscle. Do go up in the salivary glands and double check it. And increased echogeneity is not here in the upper part, but these whitish, this can be seen Hashimoto variant in severe fibrosis and also in granulomatous thyroiditis. So even if we do get many clues by measuring volume and echogeneity, actually you cannot have a definitive diagnostic by just taking into consideration one of the information. It's important when dealing with diffuse disease to check the vascularization, which can be normal, and normal means 2-3 dots of vascular signal in the thyroid, but it's important because you have a gain and you can use the gain to increase or decrease the entire exposure to vessel. You have the normal exposure or you have the normal image regimen whenever there is no vascular points in the strep muscle and in the sternocleidomastoidean muscle. So it's important this thing how to make your fine tuning on your devices. Increased vascularization is actually seen in two major situations. Whenever we have hyperfunction, so hyperproduction, hyperthyroidism, but also high values of TSH like TSH 20, 40, 50, 100 microunits per liter also associate increased vascularization. So this image, which usually is suggestive for Graves' disease, can be also seen in very, very severe hypothyroidism cases. So you cannot make a judgment or a final decision just by looking into one of the characteristics. Low vascularization means severe atrophy, severe fibrosis, severe inactive thyroid, thyroid inactive to respond to any stimulus, regardless if it's TSH or hyperactivity, and is almost null. And this is the best example for almost no activity in the thyroid at all. How do we compound all the information when we are dealing with diffuse disease? So we are doing like this. So we have to measure first the volume, all the 3 diameters, and to make the calculation, 24 milliliters right lobe, the same 3 diameters, 18 millimeter less lobes together, 39 millimeters. And we have an increased vascularization, so increased volume, hypoechogeneity, increased vascularization. You can have either of two. You can have an active form of Hashimoto diseases with huge TSHs or an active Graves. And this is when, so we have these ultrasound characteristics, but the presence of clinical signs suggestive for hyperthyroidism associated with low TSH combined with this image are highly suggestive for Graves' disease. And you make your clear diagnostic for active Graves by this, and you refer to treatment because you have a diffuse 39 millimeter thyroid, no nodular, active, fresh, so to say. So it's highly possible for this one to respond to treatment, to first line treatment. if in opposite to the first situation, here is a left lobe which is together 3.6 milliliters, a right lobe with bigger milliliters, 8.5 milliliters, so it's together 11 millimeters of the thyroid nodule, so not such a huge thing. But on the right lobe we have a nodule, and you already got the risk assessment of thyroid nodular disease, so it's a taller than wild nodule with some calcification, which with inhomogeneities seen both here, um, with significant stiffness even bigger than the nodule by itself, with increased strain ratio. So in this situation, because you have mild hypoechogeneity, mild vascularization of what? Of the diffuse here parenchyma. So these pictures were not for evaluating the nodule, because vascularization is not useful in evaluating the risk of cancer in thyroid nodules, but actually for evaluating the diffuse parenchyma. You have suggestive signs for active Graves, but because of the presence of high risk nodule, you won't refer it to treatment with thiamazole or metimazole or whatever. You will emphasize in direction the definitive surgery to cure both the disease and to get rid of the high risk nodule. Another example, right lobe 6.5 milliliters, left lobe 2.4 milliliters altogether, a volume 9.18, even less. Let's say that the mean range of normal thyroid volume, so it's for sure not increased. The echogeneity, because it's significant better than the strep muscle, it's a normal vascular echogeneity. You might even say a very mild hypoechogeneity, but it's not an active autoimmune process. Because the vascularization is some dots, it's normal vascularization, it seems to be a normal thyroid, but we have in front of us, so normal volume, normal echogeneity, normal vascularization, no symptoms. But because if we are having in front of us a patient with a history of hyperthyroidism, by ultrasound we can make a diagnostic of um, disease inactivity, of cure of the disease, so we can go to follow up. So actually, just in the same category of Graves' disease patient, first example was acute, fresh, so to say, Graves, referred to treatment. The second one, because co-association of high-risk nodules, do not lose time anymore, emphasize urge the patient in direct surgery or at least fine needle biopsy. In the last situation, clinical ultrasound clear characteristics of cure of the disease, you can refer to follow-up just by performing a simple conventional with color Doppler ultrasound. What else can we get? So we have normal volume, mild hypoechogeneity, normal vascularization. If we have a presence, because there is an inhomogeneity here and is suggestive for autoimmune disease, if you confirm with your suspicion by high values of anti-thyroid antibodies, regardless thyroperoxidase or anti-thyroglobulin antibodies, you can have the diagnostic of asymptomatic autoimmune disease and refer to follow-up. In the presence of huge volume, this 23 milliliters right lobe, big isthmus 7.5 millimeters here, and the huge left lobe in altogether 21 milliliters, so a total volume of 44 milliliters with hypoechogeneity, with a little bit of fibrotic septum here. Altogether, these images are highly suggestive for autoimmune disease, and it's very peculiar to have such a goiter without hypothyroidism. So the ultrasound image by itself is a positive, clear diagnostic of of autoimmune thyroid disease. And if you have symptoms of hypothyroidism and high TSH, which somehow you are presuming that you will see when dealing with such a picture, you know you have an active thyroid autoimmune disease, and you know you have to make referment to supplemental treatment. The same goes for such a thyroid, which is almost barely to be seen. So here is tracheal cartilage here and here. So let's stay on the left side. So a little bit of here are strap muscle, sternocleidomastoidean muscle, carotis. Here is a little bit of left lobe, transversal scan, longitudinal scan, 0.7 milliliters, and the same small image here. It seems that there's almost nothing on the right lobe, so severe atrophy. And of course, in this situation, you know this in front of you. This severe atrophy can be either because of a long-standing the end stage of autoimmune thyroid disease, or a fibrosis induced by iatrogeny, mainly radioactive iodine can induce such a severe atrophy. But if in front of you have a patient with no history of any medical, let's say, intervention, you know that this image, and this is enhanced image with Doppler, there is no activity at all. This severe atrophy is highly suggestive for end stage of autoimmune thyroid disease. And even if you don't have the possibility to have high levels of antibodies, you know that this is an atrophic autoimmune thyroid disease and you have to refer it for substitution. What can you get by making also, let's say, in dynamic on yearly basis ultrasound? So this is 2019 with a total volume of 13 milliliters. 2020, no, actually my mistake, March 2019, 13 millimeters, May 2019, 18 millimeters, and the difference are significant. In a longitudinal scan, right lobe and left lobe, so the increase in depth is suggestive. So you can have an evolutive, it's a Hashimoto type of direction, evolutive autoimmune thyroid disease. But the same is valid in this situation. So it's a thyroid in 2018, a total of 20 milliliters, and in 2019 a total of 10 milliliters. So both direction, increase in volume or decrease in volume, can be seen in the normal evolution of autoimmune thyroid disease. But actually the general appearance of hypoechoic, let's say, microgranular pattern is and will be always suggestive for autoimmune thyroid disease, and you will refer it or you will treat it with supplemental treatment if you have an associated hypothyroidism. But actually, whenever the thyroid is decreasing, you are, how should I say, dealing or presuming that you will have an increased degree of hypothyroidism under your eyes. You can also get to see the unilobular disease. So here is transversal scan with a left lobe which is small but normal. Sorry, a right lobe which is small but normal. A left lobe which is hypoechoic. When we do the longitudinal scan, this micro nodular pattern is highly suggestive for autoimmune disease, and the same goes valid for Doppler and ultrasound. So even if we have a unilateral disease, we will screen for antibodies and we will put the positive diagnostic of autoimmune thyroid disease, and we will offer treatment if we have high levels of TSH. I just skipped the nodules because we will have a very short referral about nodules at the end. What else can we see? We can see lymph nodes. So even if we are, let's say, conventional or traditional trained, that we are not get to see lymph nodes in thyroid scan, actually with high sensitive ultrasound devices, you get to see thyroid lymph nodes, even normal ones. For the easy to communicate between specialties, when dealing with laterocervical lymph nodes, we have to refer to compartments, and we have two lines, the cricoid cartilage and the hyoid bone, and then we'll have levels Behind the thyroid is department 6. Below thyroid region sternum is department 7. Lateral to thyroid is department 4. Even further lateral from or behind, when looking from anterior to posterior to the sternocleidomastoidean muscle, is department 5, divided by the cricoid line in A and B. Upper the fourth compartment, you have the third one. Behind the thyroid and upper the thyroid, we have the sixth compartment. Submandibular region, lateral 1B, medial 1A, and in mastoidean region, the level 2. And actually, when dealing with these lymph nodes, it's not always necessary to put the compartment, although it will be nice and elegant, but it's important to see the differences between lymph nodes. So this is transversal scan, which usually are not suggestive for lymph node. Usually on longitudinal scans along the carotid arteria, you will see lymph nodes, and in this situation, these are actually normal lymph nodes. So they are fine. The length is at least double than the height. You have a fine line, hyperechoic one, which is the hilum, very thin and fine and line. What else? Inflammatory type of adenopathies, typical at the level of isthmus, accompanying a clear image of autoimmune thyroid disease, is the so-called Adelphian adenopathy, which can be falsely mistaken for nodules at the level of isthmus. Reactive lymph nodes, again, a highly suggestive transverse scan, longitudinal scan of autoimmune thyroid disease, and these lymph nodes do not show so clearly the hilum, but still the length is double than the width or the height, so the Solviati index is higher than 2. And because there is the hilum is blurred, you call it reactive. Is typical reactive, especially in autoimmune diseases, in inflammatory thyroiditis, in granulomatous thyroiditis, in long-standing nodular disease. And on the opposite, the metastatic adenopathies are adenopathies which do lose or their normal appearance, are not ovoid anymore, do not show any hilum, and especially they have the same pattern or a pattern similar or highly suggestive for thyroid parenchyma. So this is a transverse section. Here the common carotid artery as a landmark. Here is part of the left lobe, and the same pattern that we see the thyroid in these structures that look like thyroid nodules but are outside the thyroid capsula, are roundish without hilum. You can get to see the image also like this. This also can be a lymph node secondary to thyroid cancer. It was a case with an adolescent girl with huge lateral cervical lymph nodes, metastases, and it's an ovoid one with no hilum and important hypoechogeneity. This is also typical a pattern whenever you see a cystic lymph node with some calcification inside, typical aspect of thyroid lymph node metastasis. And of course, the same goes for this one. So this is carotid artery, this is transversal scan, this is a tracheal left lobe, and this one has a similar pattern like the thyroid, also typical metastasis of thyroid cancer. Last but least, just short mention about thyroid nodules. So currently, there are, as you heard already, there are different patterns that we are evaluating when dealing with thyroid nodules. And the most used one are composition, solid ones, shape, ovoid or let's say wider than tall, or vertical or round where you have the taller than wide appearance. Echogeneity, homogeneity, margins, position, presence of calcification. If you have in front of you a thyroid with no nodules, you make the fine assessment thyroids 1, regardless if this is, for example, the euthyroids model, but actually there are at least 6 major thyroids models that are used currently. And used currently means uh, validated models by long number of series, by pathology reports, by fine needle aspiration reports, and also, how should I say, double check by peer review and published in important journals. And according to the number of risk categories, you will put the nodule that you see in thyroids 2, thyroids 3, 4, or 5 categories. The higher the risk category, the higher the probability of cancer. It's important to emphasize that regardless the thyroid how should I say, the thyroid's nodular model that you are using, the European one, the American one, the French one enhanced with elastography. Please keep in mind that the important thing is risk stratification. Why? Because according to the risk stratification, which means very low thyroids 2, low thyroids 3, intermediate thyroids 4A, high thyroids 4B and 5, you should refer the nodule to fine needle aspiration. And according to different um, guidelines, and you should use, let's say, more fresh guidelines like the 2016 ACE guideline. Very low is referred to fine needle when you have a 2.5 centimeter higher diameter, low 2 centimeters with proven growth, intermediate 2, and only high risk nodules should be referred to fine needle and 1. And only in the presence of very high risk personal circumstances like previous exposure to X-ray, you should refer nodules to fine needle even if they look very, very high risk and have all the ultrasound characteristics of high risk to fine needle before 1 centimeter. So risk stratification is using and choosing a risk model that is much easy for you to be used, and then refer it to the specialist or to fine needle according to the last guidelines. There are differences between the thyroid's model, and I'm dealing here only with or I'm talking only about validated thyroid's model. Caveat, be attentive, you cannot use unpublished, unverified thyroid model regardless who is recommending which type of restratification. So the European one has this sensibility but very low specificity. The American one has a greater specificity. The Horvat, which had 10 parameters, has a lower sensitivity but a higher specificity. The French one, which is the only thyroid model that also considers stiffness, meaning high density or low elasticity on elastography, has the best sensitivity and specificity and the best accuracy from all again, not what I like from the models, but actually models that are really double checked by peer reviews and published. Doppler is not included in thyroid model. Pay attention, not because it's not good, but because the central vascularization has a very small interobserval agreement. The Doppler sensitivity is very, very dependent and different from one ultrasound machine to other. The signification of seeing vascularization is different. So if I have a nodule which is less than 1 centimeter, it doesn't matter how its vascularization looks like, and who is telling you something different is wrong. Whenever you have nodules around 2 centimeters, it's not so important, but you pay attention to vascularization and you take vascularization into consideration only in nodules higher than 3 to 4 centimeters in diameters. And when dealing with thyroids meta-analysis, for example, these are some of the examples in the RAS model, this is the French thyroids, this is the Korean thyroids, this is the European thyroids, and this is the American thyroids. And the number of nodules with the validation of meta-analysis is huge. Other examples, let's say the most used and known thyroids, the Horvath model, which is the 10 parameters nodules, has the risk is increases with the thyroid category. The PARC module, which has only 5 characteristics in parameter, has even better stratification possibility. The RAS module has an elasticity as a risk. The 6 parameter of risk has even better specificity. The European, and this is the American thyroids, also different values. So be attentive if you choose what you will choose, because actually at the end, category 2 and 3 associated very, very low risk of malignancy. Category 5 and 4, which is intermediate and high risk, associate high risk of malignancy. So taking all these into consideration, you can and you should use ultrasound for screening, first-line morphological tools of screening. It's a diagnostic tool because you can go with a clear diagnostic of disease activity and inactivity, of course taking into consideration clinical and immunological clues. You can make, if you know you have in front of you a Graves' disease, a nodular disease, or an autoimmune thyroid disease, or an IDD, iodine deficiency disorder, then you know in which stage of the disease you are. You can make treatment suggestion and direction according to activity, inactivity of Graves, cure of Graves, final fibrosis of autoimmune thyroid disease, and of course, last but not least, presence of thyroid nodules, and nodular restratification, re-emphasizing with one of the major thyroid model which are currently universally used and validated and double checked by meta-analysis and by peer reviews, is all the things that you just can do on daily basis with a simple thyroid ultrasound. Thank you very much.